Trials at Vanderbilt-Ingram Cancer Center. Dr. Rini will be speaking to us today about the latest data and ongoing efforts from the COVID-19 and Cancer Consortium Registry. Welcome, Dr. Rini.
Thanks, Sonia. It's great to be here. Looking forward to the rest of the conference. And as stated, I've been the CCC19. I'm going to give you some background, but this sprung up, I guess, now over a year ago, a Vanderbilt-led consortium that's just grown like a weed. And I'm going to share with you the latest data. And then at the end, I actually stole some slides from Sonia about the disparity work that she's led within this consortium. And so I'll present those briefly as well. So I'm just going to give a refresher on CCC19. There was just data published in the first 5,000 patients. And I'll sort of walk you through some of that data and some of the highlights, and then again, present some of the disparity work. So this is the mission statement of what we call CCC19. It's really collecting and disseminating, prospective, granular, uniformly organized information. The question was really around how is this virus affecting patients with an underlying cancer, history of cancer, ongoing treatment, resected cancer, sort of the spectrum of cancer, and how is this, what are the outcomes of those patients, and how is the virus impacting them? This is just a map of participating centers. Again, this started with some activity on Twitter. I think it was March of 2020 and grew rapidly. Jeremy Warner is the head of this, who's a Vanderbilt researcher. Many of you probably know Jeremy, and has put just a ton of effort into organizing this, and I've been honored to be part of this. I won't read this slide to you, but there's a lot of people involved. And one of the downsides of this, there's so many people that are involved in this, it's impossible to give everyone the credit that they deserve. And we struggle with, authorship on papers and including everyone. And we try to include junior faculty and fellows and prioritize them, but it's really been a struggle, frankly, to sort of to get everyone the credit they deserve. And so just sort of a shout out to everyone at every level who puts effort into this. Here's sort of some of the main folks involved in terms of coordination, both at Vanderbilt and then also the steering committee, which I'm part of. And again, this is a diverse group of folks from representation. Solange Peters is president of ESMO, so we have European involvement. Corey Painter is a patient advocate, et cetera. And we're constantly trying to update this and get input and recognition sort of people across the board here. And you see Jeremy in the bottom right there. So this is, again, you see from April, basically a year over year, April to April, from last year to this year, you see sort of cumulative cases in this grew, and you see some sort of inflection points there, which is usually right before a major publication when we're sort of beating the bushes to get people to enter cases and update their cases. But you see it sort of grown almost exponentially. So this is a slide of the published manuscripts to date. I think it's relatively complete. This doesn't, of course, include the many, many abstracts. There's at ASCO and previous meetings, there's been all sorts of abstracts, but it started with the Lancet publication, which is third down there, which was May of 20. So just a couple months after. There's about 1,000 patients in that initial cohort. And then you can see many, many updates, including what I'll present to you today, which was just recently published. A lot of editorials around this, a lot of data, all sorts of different things, but it's really been sort of a rich source of academic output throughout. So here's what it is, and I won't, again, read this to you, but it's really just collecting and, collecting information on patients with cancer who have COVID infection. And you can see the different buckets of data that's collected. This has changed over time. And obviously now there's information around vaccination, et cetera. And this has really, been a work in progress, of course, as we figure out what's too granular, what's too limited, and really trying to fit the data collection to the questions that we're trying to ask and answer. So this is the analysis. Petros Grivas, who's a friend and colleague also on the steering committee, just published this in Annals of Oncology. So now there's almost 10,000 patients in the CCC19 registry. This was in the first 5,000 patients who had adequate follow-up. So rates of complications, and on the left is the initial Lancet publication, which, as I mentioned, was about 1,000 patients. And now you see about 7 months later with 5 times the numbers, just for sort of comparison on how this evolved over time. So the death rate in these patients, about 13–14%. And then one of the things we've consistently reported with this data sets are other complications, as you see listed: mechanical ventilation, ICU admission, oxygen requirement, and hospitalization. And of course, some of those things are going to vary by region and hospital, et cetera, but just to give you some idea of not just death, but the serious things that can happen to cancer patients when they get COVID. And so you see some of the numbers there: 12% mechanical ventilation, 17% ICU admission, et cetera, and a high amount of hospitalization among cancer patients. This is 30-day mortality for subgroups. So the red in the sort of the middle there, you see again the 14% mortality rate in our cohort, and then sort of listed in order of magnitude, if you will, are the percentages in other populations. So obviously in the general non-cancer population, or sort of the all-comers population, it's lower in the single digits. And then you start to, as you go down from the row in red there, you start to see other groups that are at higher risk than our cohort. Male, gender, having an active cancer that's progressing, quite obviously that's not a good thing. Age, poor performance status, and then as you start to accumulate risk factors, you get into very high levels of mortality. Obviously, elderly and poor performance status patients that require intubation are quite obviously a sick group that's not going to do well. So this is looking from a cancer standpoint at select cancers. Now, again, the cancers aren't all the same here in the sense that one group may have more metastatic representation, others may have less, et cetera, et cetera. So it's just a bucket of diagnoses, if you will. You see solid tumors there at 13%, breast and endocrine cancers a little bit lower, 6 and 8%. Hematologic neoplasms, and this has been seen in other data sets as well, appear to be at higher risk. I'm not sure that it's exactly known why, and lung cancer. So those bottom two in our cohort have been shown in other cohorts, including a lung cancer one called Teravolt that Vanderbilt's been involved in at higher. And it may be that lung cancer patients are commonly receiving combined chemoimmune regimens, et cetera. I'm not sure it's exactly known why. Obviously, they have a thoracic malignancy. So with this infection, they may run into more problems, but just some trends that we've seen over time with the various malignancies. This is just looking at general factors regarding COVID-19 severity and 30-day mortality. And the severity is one of those endpoints that I mentioned, ICU admission, intubation, et cetera. And just looking at the relative risk in these different groups. So again, age is a risk factor. You can see both for severity and mortality. And again, you get broken down into small numbers, although 5,000 total in the cohort, but you can sort of see the size of the confidence intervals. Some of them overlap one a little bit, others are distinct from one. Gender, the non-Hispanic Black versus non-Hispanic white, which I'll go into a little more detail at the end. Hispanic versus non-Hispanic white. Smoking has been a mild risk factor. Obesity, a mild risk factor. And then looking at the time of diagnosis, as you all well know, treatment's evolved. The supportive treatment has evolved quite a bit since a year ago. And you see a sort of a reduced risk of complication and death for the later diagnoses. These are some of the cancer-specific factors, again, associated with either COVID-19 severity or 30-day mortality. Performance status, just like it does in all of cancer and all of solid tumors, really drives outcome, right? And these are patients who have either bad cancers or on significant treatment, reducing their performance status. It's not surprising that they would get into more trouble with an active COVID infection. Heme malignancy, as I mentioned, appears to be a risk factor in ours and other cohorts. Not exactly sure mechanistically what the reason is. Having an active cancer that's progressing is quite obviously worse than patients who, say, had resection a year ago for a solid tumor. Again, they're likely to require active treatment. That treatment could affect their immunity, et cetera. Same with remote versus cancer. And then I don't have the data here. I think I maybe have one slide on it, trying to look at specific types of cancer therapy that might increase risk. I think the only thing that we and others have found is cytotoxic chemotherapy appears to increase risk. Again, that may play into why we see higher mortality in lung cancer patients. I guess the good news is that there's several types of cancer therapy that don't appear to impact severity and mortality. Immunotherapy, quite obviously, being a prominent one that we use across cancers. And so that doesn't appear to be associated with increased risk. And so not so much now, but when we were a little more shut down sort of last summer and deciding, gee, should we treat this patient? Should we not treat this patient? I think some of these data, more mature now, but were available at the time, were a bit reassuring that yes, we can go ahead and treat patients with immune therapy as appropriate for their cancer because we're not increasing their risk. Whereas cytotoxic chemotherapy, depending on the circumstance, we might be a little more cautious about. This is a overly complex slide. I'm sorry, but it basically just shows looking at specific regimens. And I just would refer you to the publication sort of for for the specifics, but looking, you can see the modality of anti-cancer therapy on the top there, the colored bars of endocrine, immune, chemo, and targeted as sort of general buckets. And then obviously the specific type of drug on the side, and it looks at sort of mortality in these groups. And the take-home point is really that, you know, chemotherapy appears to confer the higher risk. Multi-agent chemotherapy, cytotoxic chemotherapy confers the highest risk. So just to recap the key points. So the most recent published data is of the first 5,000 patients in the CCC19 registry. You see most of these patients hospitalized and unfortunately mortality of a 30-day mortality of 14%, you know, much higher than the general population. You see some of the risk factors for bad outcome and mortality: age, gender, obesity, comorbidities, et cetera, worse performance status, and then certain types of malignancies, like I mentioned, hematologic malignancies and lung, and the receipt of chemotherapy. I didn't, that fourth bullet, I didn't go into that data, but we've looked at all sorts of labs, and mostly the things you would think about being associated with poor outcome in cancer patients were associated in this as well: inflammatory markers and the like, as well as some specific anti-cancer therapies. And then just to recap, and thank you to Sonia for sharing these slides with me. This is an effort that she led. Just to back up 1 second, one of the things that we've done is have sort of a call for proposals. So every 2 or 3 months, we'll have a period in which we're sort of accepting new projects, and different groups around the country will sort of band together and say, hey, we want to look at, you know, prostate cancer, you know, sometimes disease-based, sometimes other questions. And it's been, you know, part of the fun of this, and also, frankly, part of the challenge, because there's so many good people with good ideas. We've sort of had a grant-style review mechanism and scores and discussion and going back and forth to try and award these, because it's just really a matter of the bandwidth to do this and the statistical support, et cetera. But this is one of those projects. I think there's, boy, I don't know the numbers, at least 20 or 30 such projects that have come from this. But this was looking at differences in baseline demographic, socioeconomic, and other characteristics, and looking at severity of COVID-19 presentation. And again, looking at COVID-associated hospitalization, ICU admission, mechanical ventilation, and the like, and then secondarily at all-cause mortality. So you can see about 2,500 non-Hispanic white and just over 1,000 non-Hispanic blacks in this cohort to date, relatively balanced in terms of age, gender, some imbalance in terms of insurance if you look at the Medicaid line there, but relatively balanced for smoking status. About 20-ish% heme malignancies, and the balance, the remainder solid tumors, again, balanced across cohorts. And then this is looking at cancer and comorbidity characteristics. You see relative equivalence across the top in terms of cancer being in remission or active cancer stable or responding, et cetera. You do see imbalances for some of the comorbidities, clearly renal disease, type 2 diabetes, and obesity, which, as I mentioned from the larger cohort data, clearly impact outcome. Patients with comorbidities who get COVID, of course, just like any other illness, are at increased risk for worsen outcome, and also worse presentation, more moderate or severe COVID-19 at presentation, imbalances as you see listed there. And then if we look at the outcomes, again, you see higher rates in non-Hispanic blacks of hospital admission, ICU admission, mechanical ventilation, and 30-day all-cause mortality. And so I think if you just put this together, and Sonia can certainly comment on this, you have a more comorbid population. You have more symptomatic disease at presentation, so delay in presentation, I'm sure, for a variety of reasons, and that leads to worse outcome. You know, it's all sort of tied together, I guess, in my opinion, teasing out, you know, which is causing what. I think it's all tied together, but we're clearly seeing about a 10% bump in bad outcomes across the board here. And so this is just a slide recapping what I just said. More likely, non-Hispanic Black patients more likely to have comorbidities, as you see listed, as they do in the general population, they do in this cancer population. And despite similar distribution of some of the other things that I said were important, including cancer type and cancer status, there's non-Hispanic Black patients present with more severe COVID-19 illness and have worse outcomes, as you see listed there, and just some of the numbers for the outcomes adjusted odds ratio are listed on the bottom. So just want to acknowledge, again, this has been an enormous amount of work. You can imagine getting this consortium up and running and being functional in the midst of a pandemic was interesting, to say the least. So a lot of credit to Jeremy and his team for doing a lot of the work. Been fortunate to get some funding support for this work. Hopefully that'll increase in the future. And again, I would just shout out, all the investigators and their junior faculty and their fellows and all the sort of heavy lifting that's being done. I think this consortium is a great example of how people came together during the pandemic, really propped this up, got it running. Again, many challenges and bumps along the way, but I think really starting to produce some quality data that I'm hopeful is informative and is actually helping us in the care of cancer patients, right? That's really what it's all about. And I think some of these data provide a backdrop for that. And I will stop, and I'm happy to take any questions if we have time.
Thanks for that awesome presentation, Dr. Rini. I think I see a question here in the chat. Have there been considerations or proposals to use these data and approaches and the consortium to predict the impact of other virus infections such as CMV, HSV, adenoviruses, and subsequent interventions?
I mean, we haven't really talked about other viruses. We've been pretty consumed with coronavirus for the last year. I don't know. And again, viruses really weren't my world before this. I'm a GU medical oncologist, so viruses really aren't part of my world in terms of what my patients get or etiology. So I'm not sure what else is up and running, or if there's certainly no data collection in CCC19 that I'm aware of that could look at this. And I'm just not aware if there are other such efforts. I assume so, but I don't have personal knowledge.
Yeah, I think Dimpi Shah on the steering committee is leading some of this work, looking at some associated other infectious diseases. Don't know the results and how that has been. I think some of that work is, going to be presented at ASCO. So I can find that out for you, Dr. Dennison, and let you know as well. Let me see. I think there's another.
It's hard to keep track of everything that's going on with this.
Absolutely.
I mean, there's 10,000 patients. I don't even know how many investigators, 500 plus. So it's just hard to keep track of everything going on.
Yeah. So there's another question asking, are cancer patients more likely to test positive for COVID-19? And if so, why?
More likely to test positive. I guess the question is the incidence higher in cancer patients? We only have cancer patients in our registry, so we don't have a separate non-cancer cohort to compare to. I'm just trying to think of other data sets I've seen. I think they would be at increased risk for infection, but I'm not sure that I could quote any data. I don't know if anybody else in the call has insight into that.
And then another question here, any data yet on how well cancer patients are protected by these mRNA vaccines?
I think no is the short answer to that. We're starting to collect vaccination data in CCC19. Quite obviously, that'll take a while to play out. We hope the rate of subsequent infection is very low. It's 5% or lower, like in the general population.
Mm-hmm.
I'm part of a different prospective trial called NCAPS, which is an NCI-led prospective study, probably end up being about 1,200 patients or so, that will look at, it's only in cancer patients, similar to CCC19, but prospective, collecting blood and tissue and whatnot. And I think one of the most interesting outcomes of that effort is going to be looking at serology over time in cancer patients who are vaccinated. And so we'll have prospective data about level of immunity, titers of antibody, durability of response, et cetera. But I'm not sure I've seen any data to date, and certainly none from this retrospective effort.
Yeah. Another very interesting question here. Could one interpret immunotherapy as being slightly protective once you have COVID-19?
Yeah. I don't know. I mean, I probably wouldn't state that in public. Obviously the hazard ratio is below 1, but it's also covering 1. And if it was 1.1, I probably wouldn't say that it's, slightly worse. So I don't know mechanistically why necessarily. I mean, Mark probably knows better why immunotherapy could be protective. Most of these patients, of course, got checkpoint inhibitors, right? That would be the most common immune therapy, probably 90+%. So, and I don't know of other data sets to suggest that it's protective. So I think maybe an interesting signal, but there's also a lot of confounding, right, of other variables of patients who get immunotherapy. So I'm not sure.